Hey, welcome everyone to our Sarcoma and Bone Cancer Awareness Month webinar. Thank you for joining us on this lovely Thursday night. I'm going to hand you over to the amazing Mr. Craig Gerrand, consultant orthopedic surgeon, who is going to take us through plenty on sarcomas, raising awareness, and we're going to have some patient video for a real life story as well. So, Craig, I will pass it over to you.
Thanks very much, and thanks for joining us this evening. Amazing. I'm guessing that's in a good way. But anyway, thanks for joining. I'll share my screen. Hopefully you can see that. Yes, I'm Craig.
Not yet. Sorry, not yet.
Have you got it? So I'm Craig Gerrand. I'm an orthopedic surgeon at the Royal National Orthopedic Hospital, Stanmore, part of the London Sarcoma Service. So my day job is looking after people with sarcoma, particularly the pelvis and extremities. So these are people of all ages, really, from children through to older patients. And this Sarcoma Awareness Month is really a charity-driven thing, because we're very fortunate in the sarcoma community in the UK to have a couple of very good charities who are basically come from patients who've clubbed together and who have developed two charities in particular, although there are a number. The Bone Cancer Research Trust have been involved in today's presentation, and also Sarcoma UK, and they provide a whole load of patient resources. And they've raised quite a lot of money. They're raising about £1 million a year now for sarcoma research, which is fantastic. And so in the 20 odd years that I've been involved in this field, we've seen these charities really go from strength to strength. And so we're grateful to BCRT for getting involved and supporting this presentation today as part of Sarcoma Awareness Month.
So sorry, of course, Craig, we can't actually see your screen if you're sharing.
Oh, okay. Okay, let me try again. Can you hear me all right? Yeah.
I can hear you fine. Can see you. Just can't see your lovely slides.
Try that. Can you see that?
No, still just looking at you at the moment.
Okay, it's definitely sharing. Okay. Oh, wait a minute.
Okay, there we go.
Okay, get in. Right, okay, that's fine. Now I can't see you, but that doesn't matter. When you speak to patients about their experiences, one of the things they very often talk about is the long time it took to make a diagnosis. And of course, sarcomas are rare things. And for every child who has pain in the knee, only one in a very large number will turn out to have a primary bone tumor. But for those, it's very important that they get picked up early. And we know that delayed diagnosis has quite a major impact on outcomes and actually on the way people relate to the health service as well. And so certainly the charities and people who work in sarcoma are very keen that people know about it and are aware of bone and soft tissue tumors as a thing, so that they might be picked up. Let me see if I can advance the slide. So I don't want to keep you all night. We'll talk a bit about what a sarcoma is, how to assess a lump, who gets them, how they're treated, and how to manage referrals, because I appreciate that for every lump that is seen, again, only a very small number will be a sarcoma. And so actually managing that process correctly has huge implications for patients, for primary care, and for the health service, and particularly we're finding for our services. So we'll just see if we can show this video. Just give me a moment. It worked a minute ago. Just give me a moment. I'm going to stop sharing that for a minute. And we'll try this. Okay, bear with me. I'll just do this and. Okay, that is not working the way it was. Sorry, folks, just give me a moment. Okay, here we go. How's that looking?
Hi, my name's Krista Bowes, and I was diagnosed with osteosarcoma in 2018. I first recognized that something was wrong about a year before I was diagnosed. I was feeling really tired, and I was having episodes of shaking and feeling sick, and I kept going back and forth to my GP saying, I think something's wrong. And they had put it down to anxiety. I was studying at the time in medical school, and I thought it was all just stress from exams, and I even at a point thought I might be gluten intolerant, so I went off gluten. And then after some time, I noticed a lump in my leg, and when I showed that to the GP, they thought it's just a sport injury, so just ignore it. And then I went to Prague on a medical student elective, and while I was there, I made a bet with a doctor over Wimbledon tennis tickets and ended up getting an MRI because I'd been complaining about pain in my leg. And then they found the tumor then. It's a bit of a surprise, a shock, really. When I was in Prague and I had the MRI scan, obviously nobody was expecting to find a cancer. They thought it might be a tear of a muscle or an injury, maybe even a hematoma, a collection of blood within the muscle in my leg. So everyone was shocked. And I was on a program doing surgery as a medical student on other people. So it was really ironic that I then got taken in to become a patient. And I was brought into another room. Quite a few nurses came in, but they only spoke Czech. Nobody really spoke English. I didn't speak any Czech. So I was told to call one person. So I called my best friend Josie and told her what they'd found. And she said, just get on a plane, come back, and we'll figure it out. So I went to the airport, got on a plane, and then instead of calling my doctor, I don't know why this sequence of events happened, but I decided to call the doctors that worked at the medical school that I was attending. I just didn't know the process, because I think normally if you're diagnosed by your GP, they tell you a plan. But because I was diagnosed abroad, there wasn't really any plan. And when I called the medical school, I obviously knew a lot of doctors on the course, and I said, I think I've got a bone cancer. Like, I don't know what to do. Where do I go? And they were really great. They were in my corner, and they helped me guide me into the right stream. I did end up seeing my GP, but it was a different GP than the one who'd missed the bone cancer. It was a different GP in the practice. And then afterwards, they directed me sort of roundabout ways eventually to UCLH and the Stanmore, where I was diagnosed officially with osteoblastic osteosarcoma. I've had a lot of treatment for my cancer. The first line treatment that I had was MAP chemotherapy, which is cisplatin, doxorubicin, and methotrexate. And it's a 5-day infusion chemotherapy that you get your PICC line and you wear it on your backpack for 5 days. And then I had that for 3 months before I then had my limb sparing surgery. So I had my femur, my knee, the top half of my tibia, and all of my 4 quads in my left leg removed. And then when they looked at the tumor under the microscope at that point in my treatment, they found, unfortunately, that the tumor had grown quite a lot in that time while on chemotherapy. So they thought it would be prudent at that point to switch chemotherapies. So I then was started on ifosfamide and etoposide, which is another type of infusion chemo that you have over 5 days. And then I also started immunotherapy, which is MEPACT or mifemertide. And I did chemo until January 2019 and immunotherapy until July 2019. And then I had a bit of a break before I was re-diagnosed. I was re-diagnosed with metastatic disease in October of 2020, which was about 1 year after I finished all of my treatment for the first diagnosis. I was having lung surgery for what they thought was endometriosis, which is when a part of your womb, of your uterus, grows in a different part of the body and starts shedding exactly like you would get a period. It could shed anywhere in the body, and then you have bleeding. And they'd seen something on my scans, but it didn't really look typical for a bone cancer metastases. So they were convinced it was this benign condition, this endometriosis. And I had an operation, and unfortunately, when they looked inside to try and remove this supposedly benign thing, they found hundreds of tumors within my pleura and in my lung. I had a little bit of a wedge resection, which is basically they just take the chunk out of the bottom of your lung. And then when I woke up, they told me it was metastatic disease, and I started my third or fourth line treatment. My third line chemo, but my fourth line treatment, which was gemcitabine and docetaxel. And then I chose, maybe rightly or wrongly, to stop treatment in order to finish medical school. And in that time, my tumors grew again, and I was luckily then started on the drug that I'm taking now, which is cabozantinib, my tyrosine kinase inhibitor. So when I was diagnosed with metastatic disease, I was told at that point that obviously I needed to restart chemotherapy, which would make me neutropenic and vulnerable to infection. And unfortunately, this was also during a COVID pandemic, which doesn't really help. And I was told that I should quit school. I was advised not to apply for foundation training for junior doctors because I would be very unlikely to succeed in medical school if I couldn't attend placement. And that was probably the worst of it. You know, getting metastatic disease, it was obviously awful, but finding out that like your biggest goal and you're so close, you can't just finish, it was heartbreaking. But I applied anyway. Which is great because I ended up stopping my treatment once it was a bit more stable, and I ended up going back to medical school and doing a condensed course in another 6 months of training, which I had to do overtime hours and extra days and things like that to make up for the time I'd missed on chemotherapy. And I managed to pass all my exams and finish, and I qualified as a doctor in June of 2021, and now I'm working as a doctor in Southwest London.
Okay, so there you go. That's Krista's story, and it's great to have a patient voice in this. And she's obviously a remarkable young woman, but tells that story of no one thinking about bone cancer and getting to that point where she finally gets a diagnosis through a somewhat circuitous route. Let me just show you. Let's go back to my slides. Okay, have you got that?
Yep, now we do.
You got it now. Okay, cool. So that Bone Cancer Research Trust we talked a little about was registered in 2006. 3 families who'd lost children to bone cancer came together, and this has grown a lot. And they are now dedicated to raising awareness with videos like this, and would like to improve outcomes for patients. Let me get on to the next one. They've got a strategy around research, support, and information and awareness. And again, there's plenty of case studies of patients who've taken a while, and often children with bone cancer take a while to be diagnosed. There's a patient who has been to the GP 4 times, and growing pains were diagnosed. And of course, usually, with bilateral discomfort, you might think of growing pains, but unilateral discomfort and a lump and possibly systemic symptoms and pain at night are things that obviously should make people think about it. But of course, you'll see, in primary care and in physiotherapy, you'll see a lot of different lumps. And of course, it's, which ones of these are sarcomas? Which ones should you be particularly concerned about? And what is a sarcoma? So sarcomas are rare malignant tumors arising from connective tissues. There's a great number of kinds, right? So there are well over 100, maybe 150 different kinds of bone and soft tissue sarcoma. And interestingly, we are finding almost every week we're now making new diagnoses because of whole genome sequencing. So we're finding new variants, which mean that we have tumors that are more accurately characterized, but turn out to be, we have an even more diverse group of tumors to deal with. They're heterogeneous in type and location, so they can occur in any anatomical site, really, but they do tend to occur around where there's most tissue. So you'll see them in the thigh, around the knee, around the shoulder, the growing areas, particularly in teenagers and young adults. The challenges, of course, are delayed diagnosis. Misdiagnosis remains a challenge. So if somebody has a label that is the wrong one, then it's very difficult to reverse that. And I suppose one of the asks is that people keep an open mind when you don't know what's wrong with the patient. And I appreciate it's very difficult with a short consultation, but often just to start at the beginning again and say, well, what could this be? And it's not necessarily the thing that the last person thought it was. Getting access to care is difficult. Patients travel from a long distance to get care. There's uncertainties about aspects of treatment with these rare conditions. Clinical trials are difficult, and we would tend to liaise with colleagues in the UK and across Europe and North America in order to do, for example, significant chemotherapy trials in something like osteosarcoma. And survival's not improving to the extent that we would like. We have seen some incremental improvements, but we would like more, really. From the patient perspective, it's a rare tumour, often incorrectly reassured. They travel for treatment, but there are charities and support available for patients. And of course, afterwards, this sort of treatment, and you heard from Krista there, is routinely life-changing. Many patients have amputations, or they have surgery that really affects their function. And so they have disability as a permanent effect, which it isn't in the way with other cancers. It's a very visible thing in many ways. It affects your mental health, your physical health. We are interested in particular how people who've had sarcoma can exercise or get back to sports. And this can be very difficult, particularly after complex limb surgery. Although, in fact, that's often an argument for some patients to have an amputation rather than a complex limb sparing operation, so they can get back to doing physical activity. Pain, sexual function, affects their lives in many ways. We have a survivorship package, a recovery package that we deliver at Stanmore's the best that we can, and we do regular holistic needs assessment to see what people who've been treated for sarcomas really need. How malignant are they? And this is a ballpark figure, of course, for a big bucket of different things, but these are, if you like, more serious than most breast cancers, not as serious as most lung cancers. So survival, if you have metastases at diagnosis, really remains around the sort of 20-30% mark at 5 years. It can be better. It can be 80% plus if you have a bone tumor without metastases and a relatively small tumor. And certainly things like tumor size and metastatic disease at presentation really make a difference to outcomes. So how rare are they? I mean, soft tissue masses are very common. Malignant soft tissue sarcomas are uncommon. So typically 1 or 2 in a GP lifetime. There are about 2,000 sarcomas in England and Wales every year. About 400 of those are primary bone tumours. There are a lot more patients who have metastatic bone disease. And for patients over 40, if they develop bony pain, they need an X-ray. And if something looks like it's aggressive on an X-ray, then that's much more likely to be metastatic bone disease than a primary bone tumour. Most are sporadic. There are some genetic influences. So patients with a strong family history of cancer, particularly at a young age, they may be at risk. It's, again, interesting that with whole genome sequencing, we seem to be picking up more patients who have germline mutations of one kind or another. And I think, although it's been overstated, I think we are entering this, we really are entering an era of a genetic revolution, really, where this kind of information is going to make a big difference to people. And it may be what makes a difference to early detection. But there are conditions, for example, neurofibromatosis, where there's a risk of developing a malignant peripheral nerve sheath tumor, where if somebody presents with that and pain, you would be particularly concerned about the chance that they may have a sarcoma. The graph on the left is soft tissue sarcoma, which you can see increases with age, and the other is bone sarcoma. So the patient you saw there was in the second decade of life, when people are growing, and then they may develop sarcomas, particularly around growing areas around the knee and around the shoulder. And there's a separate incidence as patients get older, particularly of chondrosarcoma, which is another primary bone tumor. So patients will present with pain or swelling, sometimes a pathological fracture, sometimes with neurological changes. We've seen a patient recently who had a tumor in the calf with a foot drop. And sometimes as an incidental finding, we've also had patients who've had whole body CTs or MRIs for other reasons, and we've found something that turned out to be a sarcoma. That's quite unusual though. Most things that are found incidentally turn out not to be serious. But there's a whole range of presentations. Some of these are quite obvious. If you see somebody with a big fungating lump like that, then you wouldn't hesitate, I'm sure, to send them to a sarcoma service for further investigation. But if you have a lump like the top left, maybe a bit less, and then the child in the top right has a Ewing sarcoma, and the centre has a Ewing sarcoma in the tibia, the findings there are quite subtle. You'll see there is some swelling on the left side compared to the right, but it's this could be missed, and so one would encourage a good history taking and clinical examination. We see a whole range of different things, including some quite benign things. So top left, that's an osteoid osteoma that gives night pain. Again, a rare thing, a unicameral bone cyst in the middle there, a pathological fracture through a non-ossifying fibroma. So these are benign things that sometimes show up on x-rays and are not cancer. And then we've got a couple of osteosarcomas here. These are bone-forming tumours which look aggressive on x-ray. And so for patients who have undiagnosed bony pain, an x-ray is often a very good place to start. An x-ray will often pick up a bone tumour, but if it's negative, it doesn't necessarily exclude one, unfortunately. And then if you're still concerned, then an MRI is a good second investigation. Some things occur in particular sites. So this is a chordoma, which occurs around classically around the sacrum and coccyx. So somebody with undiagnosed or somebody with persistent pain or a mass around the coccyx could have one of these, and this would need appropriate investigation if it doesn't settle. This is a tumor with, you can imagine, treating this needs an operation with significant neurological sequelae. But again, getting these when they're smaller is better. And this is something, again, you might feel around the knee. So this is a large, low-grade osteosarcoma presenting with a big lump, but quite a long history. Although this has undergone secondary dedifferentiation, and you can see that from the x-ray that it's become quite, there's something more aggressive happening at the front of the femur. But this is something that, again, might be picked up on an early clinical examination before it changes into something more serious. Pelvic sarcomas typically present late. These are often big, have difficult anatomy and poor outcomes, with a mean duration of symptoms of about 10 months. These are the sort of things that you might find: pain in the buttock, a mass, sciatica, pain in the hip, groin and low back pain. Although, of course, these are common presentations in primary care, and I appreciate that this can be quite a difficult thing to pick up. We know that patients with sarcoma will present to a variety of places. What we really want to try and avoid is patients presenting as emergencies, because we know that their outcomes tend to be poorer, as they tend to present either in crisis or after multiple tendencies elsewhere. And I sense with difficulties in primary care and increased tendencies in accident and emergency at the moment, this is probably happening more than ever. But particularly patients with, and when we looked at this national data, children with bone tumours of the spine tend to present to emergency departments rather than anything else, because they have neurological problems, and that's again a big deal. Some tumours present late. This patient had a scan, and this in fact was said to be a benign lesion, but turned out to be a chondrosarcoma and continued to grow. And that was really an issue with not great reporting, and then not following up the patient with persistent symptoms, not getting better. Gold standard treatment, early diagnosis, if you can do it, we do a careful biopsy. This diverse group of conditions is treated in quite an individual way, often with chemotherapy, then local therapy such as surgery or radiotherapy, and then more chemotherapy afterwards. And we try and look after patients afterwards with a sort of survivorship program. Services are structured centrally, so there are highly specialized units that deal with patients with sarcoma. This document, which is now nearly 20 years old, really led to a big change with the centralisation of services. And it said to run a sarcoma service, you've got to have a certain volume of cases, a certain expertise, the right kind of MDT. And this really transformed the landscape and made the services in the UK, people from the States and other parts of Europe will come and say, actually, that centralisation is really what we need. And not all countries do it like that. But that's been a very successful thing that the NHS has been able to do. They also had a peer review process, which has only just been reinstated, which meant that you could share good ideas. You could go and visit services and make sure they were up to spec, and standards were maintained as a result. And we have the British Sarcoma Group produces guidelines, for example, these ones for bone sarcomas. Patients have to travel. This is quite an old map, but it's quite typical, and it will show you some sarcoma centres and the distances that people will travel for treatment. This is the team in London. The photograph's a few years old, but you can see the size of the team. So we run a service for about 20 million of population, and it's very busy. And we need a whole bunch of people. We need clinical nurse specialists, radiologists, specialist pathologists, surgeons, oncologists, radiation oncologists, and so on. So it's really a big family of people. There's some cases. Here's a young woman in her 20s with a mass in the thigh. And again, you would expect to find that on examination. And this is a synovial sarcoma. You can see a big soft tissue mass in the quadriceps. And that's typically treated by, in this case, chemotherapy, although we don't always for soft tissue sarcoma, by surgery. And what this shows is we've preserved the vessels and taken out a big lump, and then radiotherapy. Some bone tumours will treat by excision. This is Ewing sarcoma of the fibula. You can see if that patient had an X-ray, that would be quite obvious. And we can resect the fibula with fairly low morbidity. Or we can, classically do endoprosthetic replacements of pretty much every long bone, or biological reconstruction. We have implants that get longer. These were developed at Stanmore, or biological reconstructions like this one, where we've taken a bit of bone and put it in the tibia, and this patient keeps their joints, has a very good reconstruction, and can go back to things like sport. So we have a whole sort of menu of things that we can offer. So one of the issues I've alluded to is about referrals, really. And one of the big challenge here is trying to pick up sarcomas in amongst a huge volume of other cases. They have a wide range of presentations. We're getting more and more referrals, and what we find is that people will be sent for scans, for example, in primary care, and they'll get a scan from a third-party provider that will say, well, this is a lipoma, but I can't be completely sure. We ought to send it to the sarcoma service. And the implication of that is that our referrals are going up and up, and we went up about 16% last year. This is just referrals from our service in London. And so we're getting about 8,500 referrals now. We get something like 130, 140 referrals a week from primary care, and about half from primary care, half from tertiary care. And the hit rate for the 2-week waits in primary care is about 4%. Now, I know that the incentivization is to send everything. The problem we've had with our specialist services, there's no filter in between. And so we've been getting more and more of these patients, and it's causing a problem. And this is a national phenomenon. It's causing a problem with specialist sarcoma services. And within that, the number of sarcomas we've actually diagnosed, which is the bottom graph, is about the same. So despite this increased number of referrals. The other phenomenon is, of course, when a patient gets referred on a 2-week wait pathway, although you would say, oh, it's great because we've excluded cancer, some of the people who are most affected, who are most upset about and anxious about the whole thing, are people who've turned out to have benign conditions. And so really struggling with this issue, what we've tried to do, particularly in London, is develop over the last 18 months or 2 years a hub and spoke model. And there's a number of things that have helped us with this. Community diagnostic centres have helped us with this. We've also developed particular sarcoma spokes where patients with suspected soft tissue sarcoma can go, and they would get further workup. There are areas where patients, where there aren't services like this at the moment, for example, in Kent, but we're hoping to develop those. And the idea is that patients would get a diagnosis closer to home. It would reassure them faster. and it would reduce the burden on the specialist centres. And also, we hope, improve performance against cancer waiting time standards. Although I have to say, at Stanmore, we've managed to maintain this despite the inflow. We've managed to maintain our cancer targets, but that's certainly not the case everywhere. This is the map for London, for what it's worth, with spokes and hubs, and the details of these are available online. The other thing that's helped us more recently are non-specific symptom pathways. So, for example, when it comes to bone tumours, we may get a 2-week wait referral from somewhere, recently Clacton, for example, an elderly gentleman in his 80s with an X-ray that shows something funny, and the GP obviously can't be sure, I suppose, that that's not a primary bone sarcoma, but and we offer a rapid diagnostic referral, but it's a long way to come to us. And actually, that patient is extremely unlikely to have a primary bone sarcoma and is much more likely to have metastatic bone disease. And so they now have access to a non-specific symptom pathway where somebody with imaging that's suggestive of cancer can get worked up, and they can get, for example, blood tests, including a myeloma screen, a PSA, an MRI scan of the bone, a whole body bone scan, review by a local diagnostic service. And of course, if there's a suspicion of sarcoma, they would come to us. But actually, that's a much better service, I think, for patients like that. We get a lot of lipomas, so benign things. So, a subcutaneous lipoma, one of the things that is on the guidance, so, it's fair enough, says that if a lump is bigger than 5 centimeters, it should be referred. But we can see a lot of subcutaneous lipomas. It's vanishingly rare for a subcutaneous lipoma of any size to become malignant, whatever the ultrasound says. And so typically we would get someone would feel a lump in the clinic and say, that's lipomatous, it feels subcutaneous, I think it's a lipoma. Would send the patient for a scan. The scan, possibly from a third-party provider, would say it's a lipoma, but I can't be completely sure. And then they would be referred to us. And that's a bit of a waste of time. And so patients like that next step should be to get an MRI. And so with the availability of community diagnostics, they should be able to get an MRI closer to home. And that sorts their problem out much faster and closer to home. As part of the British Sarcoma Group, we have written guidelines for how ultrasound should be done, and what should be seen with us and what doesn't need to be seen with us. So this, for example, shows an MRI of a very large subcutaneous fatty lump on the back of the neck. This is not a sarcoma and is extremely unlikely to become one. So history examination, some investigations now available before you come to primary care, and we would do a biopsy and then staging. So where we're at the moment is to say that if you have a soft tissue mass that is bigger than 5 centimeters, painful or deep, you should get imaging in the community, and an ultrasound is a really good place to start. And patients with a suspicious ultrasound should go to a local diagnostic service where they would get further investigations, such as an MRI. One of the other patient groups we see quite a lot of are people with lymphoma. That's quite difficult for us, actually, because lymphoma pathology is very specialised, and these are the patients who take a long time to diagnose if they come to a sarcoma service first. So we're very keen to send patients that we think have lymphoma, and we're pretty good at spotting it. On the basis of the imaging features, should go to a haematology service. So getting that MRI in the community means they would go directly to that. It's a curious phenomenon that actually the haematologist will take somebody suspected of lymphoma from primary care, but they won't take them from us unless we prove the diagnosis. But then that always takes a bit longer. There you go. And then refer patients to tertiary centres if they have masses which are highly suspicious or confirmed as soft tissue sarcomas. And if they have a previous recurrence, or if they've got recognised risk factors such as previous radiotherapy, Li-Fraumeni, neurofibromatosis. We're always happy to take phone calls. And I think that's kind of a way to deal with it. And I know it's really hard. And it's very hard to ring primary care. And it's quite hard to get the on-call person at Stanmore to answer the phone. But there should be somebody there who would take a message, who would be able to offer advice about patients when necessary. So there you go. So there are challenges to identifying rare cancers, particularly sarcoma, but awareness, I think, and where possible, early detection is important. 2-week wait referral pathways are the traditional way of doing it, but I don't think they're perfect. And so, we're moving more towards community-based diagnostic centre where you get early imaging, and these are increasingly available in the community. So I'm going to stop there, and I'm happy to take questions. I hope that was helpful. That's sarcoma awareness. Tick.
We do have one question in the chat from
Okay.
Stephanie.
Stephanie, what would a mass feel like? Firm, soft fluid? Can it be either joint or long bone? I guess I guess everyone will know what a lipoma feels like. Soft, subcutaneous under the skin. That feels like fat. There's quite a good clinical diagnosis, but large ones, growing, painful, get them an ultrasound. That's usually what nails it in terms of the diagnosis. If you're looking at a primary bone tumor, then you may feel a deep mass around the knee. And again, it's often the case, unfortunately, that sometimes the first person to examine a patient would be a physiotherapist. And I, again, appreciate pressures on time, but often clinical examination doesn't happen despite several visits. And that's just what patients tell me. And then, so I think, it can feel like all these things, but classically, a deep fixed mass is the sort of thing that you would worry about.
Perfect. Thank you for that. And thank you for that question, Stephanie. We have a hand up. If you would like to, unmute.
Sure. Hello, Mr. Gerrand. Thanks for the talk. This is Deco over in the States with Oncosurgical. Seen your name come up a bunch. First of all, thanks for pronouncing it correctly. We've always questioned that a little bit on our end, so that helps. So just a question. I do ask this to a lot of surgeons, but I've always kind of viewed surgery as pretty barbaric, and I don't mean that in an insulting way, but, in terms of the treatment of care moving forward for oncology, do you see in our future, maybe in our lifetime, or if not, when would you see us moving to a point where we don't need to do surgery on these patients and go through the whole chemo regime? And I guess said differently, what does cancer care look like to you in the future?
Yeah, what a great question. I mean, I think for the foreseeable, surgical removal of tumors is going to be on the menu. I think because just, if you look at, so for example, biologic therapies, immunotherapy, this kind of thing that's on the horizon, they find it very difficult to deal with big masses, with big lumps of tumor, and that tends to be what a sarcoma is. So I think probably surgical removal is going to be part of it. You would, for the foreseeable, it would be great to think that we don't do these kind of fundamentally disabling operations on patients, and we do big, operations that are, quite significant. And so one would hope not. I think things like proton therapy doesn't unfortunately reduce the need for surgery. I mean, it's a better thing. There are some, it's more targeted radiotherapy, so there are fewer side effects, but it's not moving the dial on local treatment particularly. So, I think it's an interesting question. I think there's some improvements to be made. We could be better at surgery, for sure. We could do better decision making. We can better tailor what we do to what people want. And I think that kind of tension between biologic reconstructions, amputation and implant reconstructions, we can do better. I think implants, are getting better. We routinely use 3D printed jigs now. So, I think we are getting more accurate. We've got, there's a fluorescence study coming, which means that, we'll be more accurate in theatre, meaning we'll just take the bits that have to go. But I think in the absence of a really disruptive chemotherapy or targeted agent, which, I'm not seeing yet, I think we're still going to be taking them out because they're basically big lumps of cancer. And, the fewer cells you have, the better. So yeah, it would be nice to think that in the next 20 years, we'd see that. And there may be a disruptive change that means all our surgeons are out of a job. I'd be pleased. I'd love to see it, right? But because the things we do, or particularly with kids, so 10-year-old yesterday, another one the week before that, I mean, it's awful for these kids, really. So we live in hope. We live in hope, but I don't think I'm not seeing it yet, unfortunately.
Yeah, no, thanks. Yeah, the fluorescent therapy is interesting. I think in neurosurgical environment, there's the protoporphyrin 9, I think it is, that they're injecting in. It's like a fluorescence.
More targeted, yeah.
Yeah, exactly. And just reducing what you're resecting, right? Reducing your margin. So yeah, I know it's a tough question to answer, but yeah, appreciate you sharing.
Thanks.
And I think we've got another question in the chat now from Lorraine.
Oh, there we go. Can you discuss when to do imaging in osgood schlatters in an adolescent? Thanks. Or suspected traction apophysitis? Yeah, I mean, okay, so I'm privileged to work in a hospital, and for orthopedic surgeons, it's look, feel, move, X-ray, and so I think it's hard to make a diagnosis for an orthopedic surgeon of something like osgood schlatters without an X-ray, because you don't, clinically say, oh, there's a lump there. Sporty, maybe it's bilateral, et cetera, et cetera. But we would always do an X-ray to make a diagnosis like that. I remember speaking to a patient once who told me about their child who'd had a Ewing sarcoma of the pelvis and had a diagnosis given to them a year before the cancer diagnosis of a slipped upper femoral epiphysis, and that was a diagnosis that was made without an X-ray, which seemed a bit odd to me. So I think for youngsters with bony lumps, I think you've got to have a low threshold for doing an X-ray, I think. And the emphasis has to be on making a secure diagnosis, I think. I hope that's helpful. Maybe not. Maybe lots more X-rays. But I mean, you guys are primary care are really good at safety netting, right? So always safety netting, going back to the beginning, saying, actually, is that really right? It's unilateral, that's weird. At what stage does bony lesions actually show up on X-ray? Okay, so the majority, by the time you see them, will show up on X-ray. But it is true that a normal X-ray doesn't necessarily exclude a primary bone tumor. So if you were concerned about it, then you would do an X-ray and you would safety net. And if you're really concerned, of course, particularly in a child, you would send them, and the referral pathways reflect that. So there's a lower threshold for referring a child than an adult who you think might have a primary bone tumor. I think the other thing we see is we get sent as sarcomas a bunch of things that on X-ray are benign and have been called benign. So an osteochondroma, for example, is not cancer, and so we get a few of those. I had somebody got sent up with a stage 2 osteochondral defect, which is a post-traumatic injury to the joint. It's not a cancer. and so just like things like that are quite, it's just worth sense checking sometimes.
Amazing. Anyone else? Yeah, anyone else got any questions to put in the chat, or you can take yourself off mute if need be? No? Might wrap it up there then.
Okay, thanks. I hope it's been helpful. It's been a pleasure. Thanks for the invitation.
No, thank you.
Thank
I hope
you.
everyone has enjoyed that. Enjoy your nights, everybody.